having me. I am very honored to present the presentation today. So we're going to learn about integrative approaches for pain management. So these are the objectives. We're going to discuss about the cost of pain care, definitions, relationship between pain and suffering. And of course, I'm going to mention integrative approaches and options to treat pain. And also, I will mention the current clinical practice guideline for pain management. So there's a lot of talking about integrative medicine on social media. I just want to clarify, integrative medicine is not functional medicine or lifestyle medicine. It includes integrated medicines include functional medicine, integrated medicine, spiritual medicine, so Eastern medicine, Western medicine, conventional medicine. So it's a combination of those disciplines. So this is a definition for integrated medicine. So I just want to introduce to you the definition. So integrated medicine is a practice of medicine that reaffirms the relationship between practitioner and patients. We focus on treating the whole patient by evidence. We use all the approaches that lead to the achievement of optimal health and healing. And according to the National Center of Complementary and Integrative Health, integrative healthcare brings conventional and complementary approaches together by using different intervention and treating the patient as the whole person. And of course, these 3 bullet points talking about the same thing. So we integrate different approaches in a well-coordinated care among different providers and institutions. So if you look at the cost of pain care, this numbers back 13 years ago, 2010, it cost us over $600 billion. And you look at the cost of pain care is higher. It's more expensive to treat pain care than just to treat heart disease, cancers, or diabetes combined. And you look at the cost of pain care, arthritis costs almost half of that amount, so over $300 billion. And if now we are in 2023, these numbers might be jumped higher. In 2017, it cost over $1 trillion in opioid use disorder and overdose. So we, of course, we know all about this on social media, on different conventions, we learn articles, we learn all about overdose, and of course we care about death of drug overdose. Okay, so why do we care so much about pain management recently? It's because of there's some update in the guidelines in the new state operation manual. They update the pain care management. You mentioned FTAC 697. They talk about pain care management. So the facility must ensure that pain management is provided for the residents. And of course, we have to pay attention to focus on comprehensive person-centered care plan, resident goals and preferences. They also mention about non-pharmacological interventions. So FTAC 741 comment about this regulation. So surveyors want to see that we have tried other interventions before we put patient on pain medication. In the state operation manual, we also learned the definition of medication assisted treatment, MAT. So medication assisted treatment mentioned about the use of medication in the combination of counseling and behavioral therapies to provide whole patient approach for the treatment of substance use disorder. So if you think about the whole definition, that's integrated medicine. So we use conventional medicine, and then we use other therapies to treat the patient. And in CDC clinical practice guideline also mention about non-pharmacologic treatment and non-opioid medications for the improvements in pain functions, and those comparable to the improvements associated with opioid use. So this too the focus at the second part of our presentation. And then you look up in the news, you might see this some kind of headline like this in pain medicine, talk about chronic opioid use, increased death in the hospital. And the researchers also recommends multimodal therapeutic approaches for this high-risk population. So you see how important we need to learn and to apply that to our resident to whom that we care for every day. So this is my original presentation that I present to patients in the community. I focus on chronic care management, but we all know, so for acute care, acute pain usually lasts from 1 to 4 weeks, and then subacute will last from 4 weeks to 12 weeks. So any pain that lasts in more than 12 weeks, we define as chronic pain. So chronic pain usually is pain that lasts past the normal healing time for an injury, and it might no longer serve as a warning sign of injury. Sometimes there's no clear cause for the pain, and this pain sometimes no longer serve a useful purpose and become counterproductive. I used to work in Walgreens, so whenever patient bring in a prescription to a pharmacist, the first thing we need to do is to look up on PMP website to check for when the last time the patient filled the prescription, how many days supply, where they fill all the prescription, where they get the prescription form. So sometimes I feel like I'm a police officer as a pharmacist, as a retail pharmacist, and I might think that you might feel the same thing, that we feel like we're not really healers. We're frustrated, sometimes we skeptical, and maybe sometimes you think chronic pain patients as substance abuser because they call into the office and claims med were stolen, or they cancel appointment, or especially they request early refills. And to my experience, usually they request early refills on Friday. So this is how I feel for many years, and maybe you can recall that feeling sometimes when we help patient fill the prescription. So how do the patient feel? So you have to step back and look how the patient feel when we see them that way. Of course, they feel their pain is not under control. They feel like they got disrespected sometimes, or distrusted. They feel like their honesty in questions. Of course, many patients told me that they don't want to be opioid as the first choice. They call the pharmacist and want to try something else before get on opioid, such as Norco or Tramadol. So we need to understand their needs. Of course, there's 4 needs for the patient, for chronic pain patient. They like to get rid of their pain. They want to come back to their normal life. Sometimes they want to make sense of their pain and want to get back to the sense of the control of their life. I have heard many stories from older adults in the community. And sometimes I heard that in skilled nursing or assisted living, I talk to them. I think they want to be heard, and they want their experience to be validated. So they can tell you the story over and over again from a car accident 10, 20 years ago, or when they was little, and that pain is still with them until now they 80 years old or 90 years old. So they keep telling story because they want to be heard. So it's not that they just bothering you, but might be a legit reason they want to get their experience to be validated. So there are several issues that make pain worse. So I listed out a few here: loneliness, depression, anxiety, other physical issues, financial difficulty, work stress, sticky relationship. You look at the top four: loneliness, depression, anxiety, and physical health issues. And those are the issues that our long-term care resident experience. So this depression, loneliness, anxiety, and their other condition can make their pain worse. So sometimes it's not really the physical pain, it might be something else that contribute to that pain. So when we're talking about pain, we might also consider talking about suffering. Pain and suffering, I think, will go together, but sometimes it might not go together. So suffering, the definition of suffering is the sense of distress, a sense of self that has been threatened. So I'll give you two examples here. Sometimes patients have pain but no suffering, such as giving birth of a child, right? Or sometimes patient is suffering but does not have any physical pain, such as victim of violence. I have many female older adults come to me and tell me they are victim of sexual abuse when they was little, and now it's manifest in their body as pain, and they just don't understand why. So that might be an issue. You might talk to the patient, especially female adult patients, and that might be something that they keep in their heart for a long time. Sick and disability can cause suffering because patients are worried or they feel limited. They don't know what to do. They're hopeless. So suffering is underneath of pain. So this is something that we should consider when we evaluate the patient. There are several risks in older adults in our long-term care community or assisted living, skilled nursing. Older adults have reduced renal function, cognitive impairment, polypharmacy, and comorbidities. So when we consider adding a pain medication to a regimen, make sure we understand, make sure we check the renal function so that we can reduce the risk of toxicity or overdose. Of course, in assisted living community, medication errors is a big risk for patient using opioid and in the combination of other medications. Some patient I have seen taking more than 20 or 40 medication a day. So I feel like this is a risk that we might have to help the patient to reevaluate the drug regimen. And of course, their condition, the renal, liver, GI, or their heart, all of that also important. I have physician email me and ask me why I make certain recommendation for dose reduction. I try to explain it to him that, well, it's the same patient, the same dose, but over time patients are getting older, so their kidney and the liver might slow down. So that's why we need to do gradual dose reduction, not just for psychotropic medication, but for certain high-risk medication also. Okay, we have, I know we in each state will have harm reduction program for opioid use disorder. This is some example that I show you on the screen. So SAMHSA have the opioid overdose prevention toolkit that may go into the website that helped you lay out ways to write your own policy in your facility. So this is very helpful. And then naloxone. Nowadays, I see a lot of advertisement on billboard on street in Oklahoma City, advertise naloxone. So that we have free naloxone for patient from state. And in Oklahoma, they can go to a website called okimready.org to get free naloxone. I'm sure in your state, there will be program like this to provide free naloxones to patients that use opioid, or they can walk into a pharmacy, a local pharmacy, and get a free naloxone kit. Or now it's available over the counter, or we can order it. Of course, we can always order as a prescription. So we have this, I call it a harm reduction program that can help to prevent opioid overdose. So since November of last year, we're talking about naloxone recommendation. Our United States Surgeon General has recommended that naloxone should kept on hand where there's a risk of an opioid overdose, and facilities should have a written policy to address opioid overdose. So for higher opioid dosage over 50 mme per day. So naloxone is an opioid antagonist that helps to reverse the severe respiratory depression. And I already mentioned you can use naloxone form prescription, but in facility, we can have it on e-kit or on OTC bulk formulary. So we talk about MME, this is morphine milligram equivalent. On the left side, there will be a table of different opioids and the conversion to morphine equivalent. Of course, you don't have to memorize this. I don't memorize this table. On the right side, and this is I post an example of a calculator. This is a calculator I used for many years when I calculate what's the total MME when patient on morphine, oxycodone, or tramadol, hydrocodone, or fentanyl. So I add it up and then make recommendation. Of course, when you Google the calculator, opioid conversion calculator, there's other website pop up. You might use those. Any website that you trust, you can use it to calculate the total MME for the resident, and then consider asking the provider for a naloxone to be kept on hand or to have an in-service for the med aid or CNA to watch for any opioid overdose symptoms. Okay, so we come to the second part of the presentation. So this is my favorite part, integrative approaches to pain management. So when we think about pain, usually we only think about physical pain, but in the integrative medicine world, we have to think not just physical pain, we have to think about psychological pain, social pain, and spiritual pain. And then when we understand that not just physical pain and there's other things going on in the patient lives, we might not say, hey, it's all in their head, right? Because there's something else going on. So physical pain is very obvious. The definition of physical pain is very obvious. We use in our conventional medicine world, we use medication in functional medicine world, we use supplement or we use other or lifestyle change such as diet. One thing I want to mention here about anti-inflammation diet, antioxidant diet, plant-based diet that help to reduce inflammation. This is very difficult to implement in nursing homes and long-term care assisted facility because we have standard diet, but most of our diet that not really anti-inflammation. So, and there's 8 food. This is just for your information. There's 8 food that can cause inflammation. So meat, sugar, oil, dairy, alcohol, refined grains, and food additives. So if you think about it, we have meat, we have bread, we have a lot of sugar, oil in our for resident to eat every day. So that doesn't help a lot to reduce pain. So if we want to improve patients' health, we might have to rethink the diet that we provide for our resident. Dr. Anish, if you're interested into plant-based diet, Dr. Anish, MD, is really support into plant-based diet. He convert a lot of patients with heart disease or Alzheimer's disease with plant-based diet. So if you want to do some researching on his website, on Dr. Ornish, Ornish, just for your information. And the third point I want to mention about acupressure, massage therapy, yoga, tai chi, qigong, all this you might familiar with this. You might already have it in your community or in our community outside of the nursing homes. They have it at senior centers, they have it YMCA. All of this I see is very popular nowadays. Now I want to talk about multi-reflexology. So you already know, you might already know about hand massage, foot massage. They're all about reflexology. If you Google multireflexology.com, it may talk about face reflexology. So it's a form of acupressure. You're gonna find certain pressure point that hurt and treat that pressure point until you don't feel normal again, and that help to release the pain. Washa, this is one of common way in our Asian family that I personally use a lot, washa, just to treat pain, back pain, certain pain that very minor pain. I can use washa to treat it. I have some tools here, and you can see it. It's just like a piece of plastic, but you can use a coin to do washa. So basically you just scratch the area around the pain without open wound or anything. It have to be still intact, skin still intact, and scratch it. And then after you scratch it, you might see some bruise there, and that's good. And then you put some tiger balm or Bengay around that area, and it will heal by itself. But there's a lot of misunderstanding about how Asian treat pain, and no, it's not a form of abuse. It's just a way to make sure all the nerves or blood flow to that pain area, so it's help with healing. Moxibustion, if you Google this, it looks really scary. But my teacher, when I took the multi-reflexology class, showed me a simple way. You can use a hair dryer to blow heat into around that area that help to help numb the pain and help blood flow. So it's the same idea. Okay, so supplements. I have seen a lot of supplements in assisted living and skilled nursing. With assisted living is sometimes I wonder if patients understand what supplements and why they take certain supplements. So I get this. So the next 2 slides, I use the information from the National Center of Complementary and Integrative Health, the one that I mentioned earlier at the presentation. If you want to go to that website and register, subscribe to the email. So every day, every week, they send you some information about certain supplement. It's very helpful for you to answer the resident if this supplement will help with their pain or not. And so sometimes you think certain supplement help, but then the research or the science say it might not help. Like yesterday, I received an email from NCCIH, and they say yoga is very helpful, but be careful, it may hurt you also at the same time. So little things like that can help you to improve your care for the patient. So this is just list out vitamin D might help, magnesium might help in migraine, CoQ10 might help. So, but glucosamine have little or no meaningful effect on pain. So I've seen patients take glucosamine for their arthritis, but it turned out it might not have any meaningful effect on pain. That's per research. And this is talk about ginger. Ginger may help with arthritis also, or omega-3. And then they talk about other herbs, supplements that might not reduce pain. So this is just some examples that you can look it up for certain supplements if patients have questions. So as pharmacists, we look it up. We don't remember everything. So we look it up, and I show you the way that website is very helpful if you want to, if the patient asks you if yoga gonna be helpful for their pain, and you can look it up on that website and see what the research say. And then you can say, according to research, this is what it might benefit you, it might not benefit you. So now let's turn on to psychological pain. So it is a mental suffering process caused by losses, trauma, or unexpected negative situation. I have a pharmacist friend whose husband just passed away suddenly. And every day she posts on Facebook that she's in pain. So to me, that's psychological pain. Because I feel like that's a broken heart syndrome. So this is some example of deep sorrow, sadness, depression, broken heart, regret. They are examples of psychological pain. And you see my little picture here, time and again, people transcend the paralyzing effect of psychological pain when they have sufficient contact with someone, can hear them empathically. So you see, we are that person, right? We deal with we are care providers. We're with patient all the time, and then we can listen to them, can hear them, that can help them with pain, with this kind of pain, not just give them a pill. These are options to treat psychological pain. Biofeedback, you might heard about it. Hypnosis, I love hypnosis. I have read some of the books from a psychiatrist that use hypnosis to treat pain. And I think that's very interesting. It's not hard. Some of you might already got some training about hypnotherapy, hypnosis. So if you help patient use this or teach patient how to use, self-hypnotize themselves, very easy. You might use some easy tools for them to help them, and sometimes help with their sleep also. Journaling, I have learned journaling during my fellowship program. I have tried it. It's amazing. So basically, you're gonna tell the patient to get a little notebook and then start writing out their deepest thoughts, regrets, or their thoughts about disease. And according to research, journaling will help reduce the severity of the disease. So such as diabetes or IBS. So you might encourage patients who love to write about their health, write about their understanding about disease and what do they want. So just instead of them carrying all that in their heart or in their mind, that you just have to tell them to write out so that they don't have to carry that with them all the time, and it manifests into psychological pain. Of course, we have psychotherapy, cognitive behavior therapy, meditation. Meditation, there's many different kinds of meditation. You might already be one of the expert in meditation. I find that mantra recitation is a good meditation to help them focus and be mindful that they're present when they do this activity. Heart-brain coherence breathing. This is very easy. You can teach patients just to put their hand over the chest, so cover their heart, and start counting. Breathe in 5 seconds, breathe out 5 seconds, and do it many times when they have anxiety or when they feel they're not under control. You can help teach them to breathe. And sometimes we need to practice that also. When I walk into a facility, I say chaotic, like we running around helping patients, but sometimes we forget to take care of ourselves also. So if we can practice breathing, just sit down and breathe. Take not just one deep breath, but many deep breaths. So just put your hand on your chest and start breathing. And you teach patients the same thing. They will appreciate that. You just remind them, put your hand on your heart and connect your heart with your brain and start breathing. And that will help to calm them down. So that's one of the, if you're interested in this research, there's a website called Heart Math. They do a lot of research about training patients with anxiety, with psychological issue, mental health issue, and they can measure that the difference before you breathe and during the time that you breathe. They can show you the effect that do make a difference. Breathing do make a difference in the psychological health. So what is social pain? Social pain is obvious. It's painful emotions that got being rejected or being alone, get abandoned. And you can see some nursing home residents feel like they got abandoned by their kids. I have a patient tell me stories. I'm not sure it's true or not, but he say that his daughter throw him into the nursing home and get all his money. So, and maybe that's how he feel, the rejection. And then every time I visit that nursing home, I always ask him, how do you feel? Do you feel, how do people here treat you? And he's happy. He's very happy. He say, people here treat me like a family. So that's one way to help with his being abandoned by his daughter. So it's very helpful to be in a community that we care for the patient as family. And of course, this is very easy to treat social pain, I guess. In our community, of course, we have different activities, programs, exercise, music, and sometimes they just get family come in or a friend come in to have lunch with them. So this is, I think we are good at treat social pain, and I'm very grateful to see people or our residents smile with go into different activities and have fun. Okay, let's talk about spiritual pain. So this is 2 definitions. So pain that comes from a hidden area of our life, it cannot point on pain scale. So usually before I see a med aid give pain medication to a resident, a PIN, pain medication, usually the med aid will ask, what is your pain scale? So, and the patient say, I don't know. And med aid say, you have to give me a number. So, and I watch med pass. That's how it happens. So patient just give the metadata number so they can document it. So this is how we go with treating pain according to the pain scale, right? But spiritual pain come from hidden areas, so they can't tell you they're in pain, but they just can't tell you a number. Say, I don't know. I'm in pain, but I don't know where it's come from, or but it is real. I can tell you, it's many times we just ignore this part of our treatment, and I really want that we might consider more considerate in this spiritual pain. So according to the North American Nursing and Diagnosis Association, they describe spiritual pain as a disruption in the principle with affect the patient entire being and biological nature. So it's something that we might not understand it today, but as now you go back to your community, you might consider it more and more about this type of pain. And if you Google about spiritual pain after this presentation, there will be a lot of articles talking about spirituality and pain, spiritual pain and suffering, all types of articles that it might catch your eyes to read, understand more about spiritual pain. I know that Harvard do a spirit trial on a few years ago for a mental health patient, and spirituality does have a role in mental health, and now they have more research about its roles in pain medicine also. So this the list of consideration when we assess for spiritual pain. So when we ask patient about spiritual pain, sometimes we have to be careful because they, due to level of stress or distress with their diagnosis or prognosis and their relationship with their family or their point of view about spiritual or religious involvement. So if you ask a Catholic, a regular Catholic and or an occasional Catholic, or a Catholic that never go to church, or a Christian, their answer might be different. So so that's why it's very important you assess those feelings about religion. We talk about religion or feelings about a faith community. So that might give you an idea where to go in the next step. So I do some reading about Christian tradition over spiritual pain and suffering, and then I pick another religion. And of course, after this presentation, you can always do research about different other religion so that you can, or culture, so you understand more about your population of resident, what do they believe in, and then you use that from their point of view, you can help them heal or talk to them and understand them more. So this is from Christian traditions. If you Google a lot of treatment from Catholic organizations, health organizations, they talk about meaning, the meaning behind life, forgiveness, relationship, and hope. So this is the 4 main points, 4 categories that they talk about when they assess spiritual pain and suffering. And they do have some organization, they have like 2 or 3 pages of assessment that you go through and ask the patient. So if you don't want where to go, you can always look for those samples and then use them to try to ask patients certain questions. They'll teach you how to ask certain patient about spiritual pain or suffering. So for the last 10 months, I do a lot of research in Buddhism. I'm a Christian, but I picked Buddhism as my research project for my spiritual medicine project. So I put Buddhism. So in Buddhism, they talk a lot about spiritual pain and suffering. The reason why they mention so much about the law of cause and effect. And so Buddhists have to understand that they have to accept the total responsibilities, which means if you're sick, you take care of yourself. You have to understand it, not depend on not just depend on other people to take care of that disease for you. So you have to be a part of the healthcare system. You don't just depend on physicians or nurses to take care of you, but you also take the responsibility to understand and help yourself heal. So with pain, specifically, they teach the followers to avoid harming or killing, or indirectly or directly, not just other human beings, but also for living creatures. So that's why they support plant-based diet. They say that plant-based diet is a way to reduce this issue, so we don't have to eat meat, so we don't have to kill other animals. So that's relate with plant-based diet or vegan diet. They also mention about practice giving away power, money, times, things, so all the baggages that you carry with you that not helping you heal. So I have seen this in the community, in long-term care community. I've seen residents go out and give away their bracelets or candies. And I think it's I think it's very easy to practice giving little things and make other people happy. They also mention about practice repentance and compassion. They say it's very important that you understand what you have done to others, and now it come back to you. Just like karma. So you reduce your karma by pay attention to what you do to others. They teach so in Buddha teaching, they teach about the mind instead of body. And this is the two sutras that I researched for the last 10 months. I read a lot about them, their treatment about disease and how people end up with disease. This is just some examples that they talk about in those sutras. So sutras like teaching, just like the Bible in our Christian tradition. Okay, now back to state operation manual. So in state operation manuals, the new updated version, they talk about the non-pharmacologic intervention. So you can, if you don't remember what I say during this presentation, you can always go back to the state operation manual for nursing homes. So they recommend a lot of interventions such as check for the environment or use acupressure, acupuncture. They recommend use TENS units or use ice pack or heat to help with minor pain. They mention about exercise. They mention about cognitive behavior interventions, relaxation technique that I mentioned earlier, music therapy, and also they recommend to offer spiritual support and comfort. And of course, we not just offer Christian spiritual support. I would think we might have to offer other religion spiritual support also. And it depends on the area. And if you have a lot of Asian patient, you might, or who don't believe in, who don't have a Christian belief, then you might have to go into Buddhism or Hinduism or Muslim. So it just depends, and you teach patient different techniques and then educate them more about pain, different kind of pain. For the current CDC guidelines, they mention about non-pharmacological treatments and non-opioid medications. They have 12 recommendations in their guidelines. And the first two that we're going to discuss will mention more about non-pharmacologic treatment and non-opioid medication. So number one recommendation talk about the common therapies that help with acute pain. So with acute pain, they want the patient to use non-pharmacological, non-opioid therapies before consider opioid therapy. And so this acute pain, such as low back pain, neck pain, any minor pain, can use NSAIDs or Tylenol. You can use ice, heat, massage, acupuncture. So this are recommended before we put patient on, or before we give patient any Norco or something stronger. Recommendation number two from this guidelines for subacute and chronic pain. Again, they also mention about recommending non-pharmacologic, non-opioid therapies before initiating opioid therapy, and only do that when you have benefits outweighs the risk. And we have to counsel the patient about the risk, and they talk about if it's not working, then we should discontinue the medication. So they also list out a lot of non-invasive, non-pharmacological approaches. So if you read all this, it's basically similar to all the stuff that I have mentioned earlier. So they talk about yoga, Tai Chi, they talk about mindfulness practice, massage, Tai Chi, acupuncture. So very similar recommendation with the say operation menu. Okay, regarding to the non-opioid medications, so we may use amitriptyline, duloxetine, gabapentin for neuropathic pain. But however, you have to be careful when you start patient on this medication because there's a risk of confusion and falls in older adults. So make sure you check with your consultant pharmacist when you put patients on this medication to see if appropriate for the patient or not. And of course, you use it if it works to improve patient pain, function, and quality of life, we can always, go for it. But again, make sure you have pharmacists that do case by case basis assessments for each patient. The CDC guideline also remind us not to use opioid as a first line of therapy. And if we use it only as needed, use the immediate release opioid. I have seen orders for OxyContin. Instead of oxycodone, they put OxyContin as needed. And that's not appropriate. So I usually ask the doctor if we can DC that, put on patient on oxycodone. Maybe just an error in transcription, but it's sometimes that it's a catch that help to reduce medication error. There's some barriers. All of this easier say than done, right? When complementary health approaches usually not covered by insurance or not fully covered, and then a lot of patients do have low incomes, or they don't have insurance, they don't have transportations, or they might live in the rural areas that don't have these services. So those are barriers, and we have to think about low cost options. Usually I ask the patient just go out and have a walk in the garden on bare feet, just to get some, we call it earthing. I don't know if you heard about it, but helping to help patient connect to the nature. and sometimes it just heal themselves. They can walk in the public, then go onto YouTube and do internet exercise program. I have seen some videos, TVs that just on all the time in some of the assisted living, and patients just watch those TV program and then do the exercise. And I think it's very, very helpful for the patient. This is again just a summary of the comprehensive care plan. Of course, we're gonna review all the medications to ensure pain is addressed. We educate patients about opioids, and of course, we have to look monitoring for their cognitive impairment, risk assessments for falls, exercise, and of course, you have to worry about constipation when patient taking opioid. So take-home messages. We should review all the low-cost option for the patient, and always tell the patient that we emphasize on improvement in function as primary goal, because sometimes pain cannot be eliminated 100%, but can help them to get back into their life. And sometimes that's all they care. And then we always look into integrative approaches, bringing conventional and complementary approaches together to treat patient as a whole person in a coordinated way. And that's it. Thank you very much for your time.